Good afternoon, and welcome to Developing a Patient Engagement Strategy that Avoids Vendor Sprawl, a Health System CIO Media Inc. production sponsored by Luma Health. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the founder and editor-in-chief of Health System CIO, and I'll be your moderator today. We're looking forward to your participation. You can send in your questions or comments at any time in the Q&A box, and we'll take them later in the program. Just so you see how we're going to spend our time today, first we're going to go about 35 to 40 minutes with our main panel discussion featuring Dr. Zafar Chaudry, SVP and CIO with Seattle Children's Hospital, Dr. Dick Taylor, Chief Clinical Informatics Officer with BJC Healthcare, and Aditya Vansad, co-founder and CTO with Luma Health. And then we will have our audience Q&A. So let's jump right in. Zafar, you want to start off by giving us an overview of your organization and your role?
Hi, everyone. Thanks for having me on this panel today. Zafar Chaudry over at Seattle Children's. So Seattle Children's is a pediatric health system based in the Pacific Northwest out of Seattle. We are 46 sites across Washington, Alaska, Montana, and Idaho. And in addition to our medical facilities, we also have a research institute.
Very good. Excellent. Dick.
Yeah, I'm Dick Taylor. I'm the Chief Clinical Informatics Officer for BJC Healthcare and Washington University in St. Louis. So it's a combination of an academic health system, a 14 hospital integrated healthcare delivery system. We're actually part of a larger system called BJC Health System now. As of the first of this year, we're a 28 hospital system. And I serve both as a leader of the EMR system and also as the director of a large and growing group of clinical informaticians.
Excellent. Very good. Aditya.
Pleasure to be here with everybody today. My name's Aditya. I'm one of the founders and CTO at Luma Health. Luma Health, we were founded in 2015 on a very, very simple premise, which is needing care is hard, but being able to get care shouldn't be. And we've been working for almost 10 years on building a set of product solutions to help patients in their most dire time, which is the moment they need care. Working with partners across the entire healthcare ecosystem, from large IDNs all the way down to smaller clinics and facility groups, kind of helping them deliver on that vision of making sure healthcare, one word, gets out of the way of healthcare, two words.
All right. Excellent. Very good. All right, Zafar, we'll start with you. Let's start by talking about the larger trend of application rationalization in healthcare. What is causing the push to shrink the existing application portfolio, and how strong is it? And how does the rationalization trend influence new purchasing decisions?
So I think the concept of application rationalization actually never went away. We've been talking about this for years on end because we do have application sprawl. When I look at my own organization, I'm running about 1,700 different applications between clinical and non-clinical. And the reason why everybody wants to rationalize applications is the cost of running them, right? So you've got maintenance, software, sometimes hardware refreshes that you have to do, as well as you have to water and feed those applications with subject matter experts, which is sometimes hard to find, especially if the application is built by two people on a boat somewhere in some remote island, right? Which is common in healthcare. So I think people are looking at it from a cost perspective. The challenge we've seen, and we've been doing this for years too, and we've probably rationalized about 300 so far of the existing number we had, is, how do you actually deprecate an application if you don't know who the subject matter expert is? And also, how do you then archive the data that may be required? So pediatrics is interesting because we're supposed to keep the data for about 15 years after the last episode of care. So if I have a small clinical application that I do want to rationalize, I still have to be able to show that data, make it available to the clinical staff, because that's the requirement in there. And then there's a cost to build the archive to actually make that happen. So it sounds very sexy. Yes,
Yeah.
let's look at all the applications, let's run through them, deprecate them, get approvals, have a committee, etc. But the reality of what I've seen, my journey in this space, is it takes time, it takes a lot of collaboration. Many people have to make that decision before you actually get to a point where you could deprecate, and the data will pretty much still have to be available for a period of time. So that's sort of the journey I've seen in this space, but I think people have been talking about this for year on year, for years on end.
Yeah, so it's interesting. It becomes like everything else, a cost benefit
Yeah.
discussion, right? Because it's very, very difficult to do, very hard to get the users to want to give up what they're using. There's so many other challenges in doing it. I interviewed someone the other day who said they put in a big application rationalization push and found that they were able to retire many fewer applications than they had hoped. So cost benefit. Dick, let's go to you. Your thoughts here, and maybe you want to also touch on that. Um, if you know, we know it's super hard to remove applications, to sunset applications. We know that, and I would think that the more we realize that, the more that bar would ratchet up of bringing in new pieces of software that we know are going to be very difficult to ever get rid of. Anyway, your thoughts, Dick.
Yeah. So you've got it exactly right, and Zafar is exactly right. It is hard to get rid of applications once you have them, particularly if you have an entrenched group of subject matter experts who really think that this is the best application for them. And so, to the greatest extent possible, obviously, what we want to do is not bring them in the first place. That requires, though, that you first understand what people are considering, and also that you then put together a rubric where you can say, no, first we're going to consider what we already have. It's the other thing, of course, is this also tends to shortcut the question of, well, can we just build one? And a lot of organizations also have the wherewithal. Certainly, I know that Zafar, I'm sure your organization does, and ours does as well. The ability to say, oh, let's just build a web app for this. Well, then you own it, and then it owns you. And that's also true for some of these applications that, like you said, it was built a while ago. The technology is a little creaky. Maybe we're not sure how it works, and but we now we have to try and get rid of it. So really, on the front end, what we say is, okay, we'd rather buy than build. We'd actually rather use what we've already got than buy anything new. We'd rather buy something new than build something ourselves. And then you have to put some teeth to it. And so you have to say, okay, why not our primary EMR vendor if this duplicates functionality in the EMR? And what functionality is unique to this thing? And really kind of getting into that in a collaborative way. And I think one of the keys for us has been to take a problem-based approach. Rather than saying, okay, what system do you want? Really work upstream and say, what problem are you trying to solve? What's the issue in your clinic today that is causing you to want to go get a new application? What's the new service you're bringing on where you think you need new software? And if we can get it at that level, frequently we can say, look, you may not know this because you wouldn't have had any reason to, but we actually already have software that can do this, and here it is. Everything runs faster, everything runs smoother, everything runs less expensively. So yeah, the more we can prevent it before it happens, the better off we are. And the other piece, I guess the last piece, is when we buy something, what else do we get with it? And make sure that whatever we're doing is both fit for this purpose, but we've also considered other things that may be put to. So I'd rather have one extra vendor than 10. I'd rather have one vendor that can serve most of our needs. And the analogy is violent, but the fewer throats to choke, the better.
No, yeah, makes sense. Very good. Adita, what are your thoughts?
I was thinking of reflecting on what Dick was saying, and I hosted a Chime focus group a couple in LA at Vibe, and the comment that you were making, Dick, was actually very much echoed by one of the panelists in that focus group of CIOs, which was really around how do you make sure that any application that you purchase, there's two parts to it. Any new application that comes to a CIO or comes to a governance committee for approval, many times like the line of service line's already decided that I've gotten, emotional commitment, not like necessary financial commitment, but emotional commitment to this purchase. And the challenge is like, they've already gotten down that path versus like looking at the alternatives that exist in the IT portfolio, right? And they actually don't necessarily start from first principles and look at what's the problem to solve, and then working with IT to actually understand what's in the portfolio to go solve that problem. And I can understand why that happens. You get kind of far, like radiology gets kind of far down a path and they like an idea, and then like, it's that emotional commitment. And I think, Anthony, one of the other things I think a lot about when we're thinking about rationalization, thinking about, simplification of the IT stack, one of the big questions is if you do bring in a vendor or a solution, I should say, to collapse 4, 5, 6 apps into one, what are the vestiges or the appendages that are still left behind? And we've gone into a fair number of kind of our customers and our clients and our prospects said, look, you could purchase Luma. And they're like, well, you have all these capabilities, or, this other thing has all these capabilities. You're lacking these two. And so we may shrink our footprint on one application, but we're going to keep these vestiges or these appendages around. And that becomes, I think, really challenging because, you either one of two things happens. Either you make the choice and you have a lot of unhappy end users, or you soft shoe the choice and you, instead of rationalizing, you've actually irrationalized. I don't know if that's the right way to put it, but you've actually added more complexity to the IT stack. So I think one of the things to really consider, when we're looking at any rationalization or any simplification story, is connectivity to the underlying, sources of truth, whether that's the EHR, your CRM, whatever it might be, because truth needs to flow down. And I think, Zafar, as you were saying, like, 15 years of data retention, kind of let it live in media, or do I have to have it in a data lake somewhere, right? So like, return economics to the source of truth. That's kind of number one. Number two is like making sure there aren't these little like, dangling side. And I was like, oh, one department used this one tool for this one thing, but that was a one-off case and the rest of the ecosystem is using it for this other case. So I still got to support it for that team there. I think that becomes a very, you don't know if you get the ROI on the activity if you still have little dangling bits of the applications and the services in the ecosystem.
Yeah, it makes me think you have to be, if you're going to go down this road, you have to be, I don't know if aggressive is the right word, but Anita, to your point, um, you have to have some courage here and, um, just cut these things out. And it makes me think of, I read the biography on Elon Musk, the big one that came out, and one of the things he would talk about in um, reducing complexity and simplifying the floor of his factories was, if there's even a hint that we can get rid of a step or get rid of something, get rid of it. And let's overdo it and then deal with that. Put a couple things back in. It's okay. If you're not putting things back in, you didn't cut enough. So that's kind of an interesting concept that makes me think that's the only way you're going to get rid of these sort of vestigial pieces, is to be very aggressive and bold. But let's go to our next question, and we're going to take this conversation about application rationalization, and we're going to bring it to patient engagement, because this could be one area where you could wind up in this predicament of bringing on a number of point solutions and sort of get away from any rationalization that you want to do. Let's start with you, Dick. How do you define patient engagement? What components of patient engagement could potentially line up with distinct point solutions? So how could you get yourself into a pickle here? And
Sure.
does this create a danger of adding a number of non-integrated solutions? This is the real important thing, right, Dick? If
Yeah.
we're if we if in order to do the problem or address the problem, whatever the operational problem, the clinical problem, if in order to address it properly, we need data to come together, we don't want to ultimately be buying point solutions that are going to be a tremendous amount of work now to bring that data together to provide that view that is the ultimate end goal, right? We want to get away from that. But anyway, your thoughts, Dick.
Yeah, so first of all, defining patient engagement is pretty simple for us. It's any time that we have the patient or their proxy engaging directly with our system in a digital way. And so that includes everything from their initial contacts with a health system defined a provider, all the way through episodes of care, Basically, anytime the patient touches it digitally is probably the broadest definition. And there's a lot of points of patient engagement that are obviously, we use Epic. My chart gives us a lot of ability to reach out and reach the patient. We have good use of proxy. We have good use of adolescent proxy. That's a little bit of a challenge. Like Zafar, I'm a pediatrician, and so I think about pediatric use cases a lot. Where you get into some of the places where your patient engagement systems just don't reach, where your primary EMR can't be that solution, really are areas either where the record is not yet created, so the initial engagement pieces, where contributors to the record are coming from different places. And a good example of that, a pediatric example, is where we're trying to get a survey completed by a teacher for an ADHD workup, and the teacher doesn't have a role in the EHR. And so you kind of need a point solution for that to get the questionnaire to the teacher and then bring it back. And yes, that's a huge risk of creating proliferation for two reasons. One is because a lot of the vendors like to store a bunch of data in their own system because obviously that data is useful for them. The problem is, to the point it becomes electronic health record data, I need it in our primary EHR because, among other things, I've got to share it with the patient. And so the idea of large collections of the records sitting outside of the EHR is pretty much anathema. The other issue is just everybody's got their own favorite vendor for this particular kind of a questionnaire. And like I said, I don't want 10 of those vendors all lining up trying to bid for the next questionnaire. It's not healthy. Couple of things we have done with this to avoid some of these problems. The first is we have an absolute ironclad rule, which is that if you are going to practice medicine, the record is in Epic. And that means anything you do from a patient engagement perspective that creates any portion of the record has to integrate that data in a structured manner back into our record. There's nothing that isn't evanescent outside of the EHR. And that's particularly true because of the retention issues and the 21st century cures issues. The other is where we have a hybrid use case, and ADHD workup is my favorite current case. The patient and their family can be inside the EHR and should be. The point solution for a teacher or an outside counselor may very well be outside the record. There may be a necessary point solution, but it's the minimum necessary use of the outside vendor. And we work with vendors who are comfortable with that. And they say, look, there's always going to be places that your primary EHR can't cover, and that's where we live. If they say, well, no, actually, we want to be your number one solution for patient engagement, and we want to own everything from your contact center to all of the various different pieces, that's where we start to say, we're not building a parallel shadow record, and we're just not. And so we're pretty upfront about this in the contracting process and in the implementation process. But yeah, constant problem. It's going to happen. We're very comfortable with it happening, and we've got a lot of defenses in place to try and keep it from getting out of control. It's a bunch of what we do.
Excellent, very good, Aditya.
Yeah, I mean, I think that's I kind of take a little more zoomed out approach and a thought here, which is, when Luma, and we started the company in 2015, I think that the timeline and kind of the evolution of EHR interoperability plays a really important role in how one can even think about some of these pieces. Like if you go back to 2015, like there was very little like Cerner code programs or Oracle OPN. App Orchard was, it's now Showroom, but it was barely like a small little like, nugget of thing inside of the Epic universe. Now there's a very robust and rich community there. Meditech didn't have the Alliance program, right? So like there's just the evolution of openness in the world of EHR. I think, there's a lot of stuff on, HTI1 that's pushing that, US CDI, V1, V3 that's pushing that, kind of like a lot of regulatory frameworks that are kind of pushing that. But, I think overall the motion there becomes very important for doing that one thing, which I think is so important, which is there's one source of truth in healthcare. Otherwise, healthcare doesn't function. Right, your HIM team can't go look when a legal request comes in at 14 different applications to source records. That's crazy making, right? And so when we think a lot about how do solutions have to operate in the context of the health IT infrastructure, it's really about returning economics to the core application record. right? It's really about how do we actually push that data bidirectionally into a flow sheet, to use Epic terminology, into a, you know, patient record, or into whatever it might be, whatever the natural home is for this piece of data. Because ultimately the goal of, I think, anyone who lives inside the health IT stack is to make end users' lives easier. It's not really, if you're not doing that, you really don't have a reason to exist inside the ecosystem, right? Because we're ultimately, like, you know, we at Luma, we measure net promoter score, we measure customer satisfaction, we measure a lot of these different things, which ultimately a reflection of, did we do our job of making the end user's job easier? And if we can say yes to that, you know, we've done a good job. And we've learned over the years that a lot of that has to do with, I think, what, you know, both you, Dick, and you, Zafar, know as like CIOs, is it's, you know, how well do you integrate into a single source record inside the primary electronic health record? So I think like that's critical, and anything that's short of that, like, and, you know, I think if you have a governance capability that says like, hard no, like if you don't do that, like don't even knock on my door, I think that's actually a really powerful statement. Because I think one of the other things that we all have to learn is, as a healthcare ecosystem, is how to actually, on your side of the table, for the audience, I sit on the vendor side, is actually how to help the vendor side evolve. Because you will find gaps in the ecosystem, you will find gaps in your primary vendors, and there will be vendors like us who our goal is to help fill those, but we have to evolve with your needs too, right? And your needs are around, you know, HIM, your needs are around compliance, your needs are around, you know, 15 years of data provenance and data integrity, right? And so that's a very good yin and yang around that, like, second bullet that we've got on the slide. Because patient engagement, I think, you know, if I think about what patient engagement is, it's easy to, I think I would even zoom out maybe a little bit from, you know, and Dick, I'd be curious to get your take here, and, you know, Zafar as well, of course. It's not just those digital touch points, but like it's also those semi-digital touch points. Like, it's so hard, like, is the Wi-Fi in the L&D ward good, right? Because you're going to have to log in, you're going to have to like identify yourself, you're going to have to click on a terms of use sort of thing, right? And it is part of the digital experience that your services provide to patients, caretakers, loved ones, and all those sorts of things. So like patient engagement is really like, you know, patient's journeys engagement, or the patients plural. I don't have a better set of words for it, but I think we have to think about the holistic experience. As long as it's returning economics to that core electronic record, you know, I think we're moving towards a good area. But I really think of patient engagement as every single touch point that is in that patient and patient's loved one's journey, that starts from the moment they want care. That could be super upstream, right? Like your Google search results. Like, I don't see how that's not patient engagement, right? But it lives in the marketing team typically. But it's very much like patient engagement, right? Or it's lead engagement, and we want them to become patients. Down to that Wi-Fi in the L&D ward, down to, you know, your post-discharge, the ADHD, or, you know, like, you know, things that happen out in the community too. So I take like a very broad view of it. I think kind of because those are all areas that ultimately, when I have a brand identity or brand recognition with BJC or with Seattle Children's, it starts with the billboard I saw and the QR code I scanned. It starts with a Google search I did that landed, that got me to a clinic.
Yep. Yeah, and I would say that you're exactly right. And I would also point out that in that L&D ward, we create a brand new patient, and that that from their first moments, we have a record. And so their digital engagement starts long before they're aware of it, but it starts with family engagement. And yeah, we cast a pretty broad net. The other thing I would say very quickly is that, because I said this morning in a conversation we were having about patient engagement, was the patient lives their life in a continuous fashion. We may see them episodically, we may touch them periodically, but they need a continuous, consistent experience, because they live their life in a linear fashion. They don't see themselves with a series of encounters. So it's an interesting point, and I think it's a really important one.
Zafar, your thoughts? A lot of stuff in there. So whatever's
So
come
I
to
think
mind.
the way I sort of look at this is, we want patients to take an active role in their healthcare, and we want them to work together with our healthcare providers so they achieve the best outcomes. And so you have to sort of look at the risk profile of what you're trying to achieve. Because I agree, if you have a core application, you would want to use that core application for most things that application could potentially do. But what you probably don't want to do is hope and pray that that core application provider will give you the functionality that you need today, because you might have to wait 5 years for that functionality, which would then impact that patient's care in some shape or form. So the way I look at this is, look at the the risk profile of what you're trying to achieve. I agree that we have to do a better job of encouraging our partners in the vendor space to be able to share data seamlessly backwards and forth, which doesn't always happen. But what is the use case we are trying to solve for? So if we need something in our organization and we need it today because it's a patient safety issue or it's a risk issue, and I'm not going to tell my clinicians that which is going to have to wait because the vendor knows best. I think what we're going to do is to work with maybe an alternative vendor in this space. But I always get agreement that once our core systems align that functionality, we'll bring it all back into that core system at some point so that I'm not holding people back. Because some of the discussions I tend to have, and I'm sure others on the call have as well, is when you're trying to explain, and yes, I have to put my IT hat on and try and explain why best of breed doesn't necessarily always give you what you want. I also have to fight the battle of a clinician telling me that they really need a tool now because the need is today. And so we have to find that balance between the need, the risk, the ethics around it, as well as giving that functionality to improve and progress that patient care. But I think there's a lot of work that still needs to be done in collaboration with the vendor space to make sure that they are allowing us to exchange data. And then I agree with Dr. Taylor that absolutely you still need that single version of the truth, and you have to agree that single version of the truth. But in practicality, what I found is some of this work that we're trying to do is like pulling your teeth out because everybody doesn't want to agree to what should be a standardized way of taking care of the patient. And really, all of us here, whether we're on the provider side or we've got vendor partner here on this call, we're all trying to get to the same place, right? We're trying to make sure the patient gets treated quickly, fast, the data's available, and the experience is seamless. But I've yet to actually get to that seamless level. So I think there's lots of different pieces to the puzzle of this, but we can't ignore the ask of the customer we have. Otherwise, it gets to be an ugly conversation. So I don't want to be the IT person in the room saying, you cannot absolutely do this. But I also want to be the IT person working with my partner ecosystem to say, you need to come to this party and help me get to where we need to be.
Yeah, I think that the temporality, the things that Luma Healthcare was offering in 2015 are duplicative of what we've got today from our vendors. On the other hand, in 2015, they were novel, and the whole idea of the point solutions is that we've purchased them. And I think the concept of a software lifecycle where you say, look, we're going to buy this, we're going to have it for a period of time, and then if the vendor has synced up with us, we will transition to the vendor. We get those agreements up front, Dr. Chaudry, just like you do. This is something. It's a critical part of our process, and then working with our vendors to say, look, the only way you're going to not be ground into the dust by these large EHRs is by being more nimble and by recognizing that they can't do everything and think of everything either. So what are you doing today? And how can we help you? Aditya, you talked about integration. Fire has been a real touch point for me, not because Fire is perfect. Fire is anything but perfect, and there's about 4 things it does that drive me nuts. But it's a great touch point because if I talk to a vendor and the vendor is not basically saying, look, we're using Fire for everything we can and HL7 version 2 for everything we can't, then I know that they're not really thinking in that way that makes me think they're going to have the velocity to stay where I need them to be. If you stop, you're dead. You have to run as hard as you can just to stay in one place in this business. And I think the faster that vendors realize that, the more likely they are to be good partners for us.
One of the funny things that we talk a lot about in healthcare, like people outside of healthcare, is like, oh, healthcare is a slow moving entity. Healthcare is like, I think that's absolutely couldn't be further from the truth,
Right.
right? I mean, you guys both have, clinicians and providers in your universes who are demanding things, every single day of you. And, we on our side, if we, I like that, just ground to dust. Like if we just sat and did the same thing we did in 2015, I mean, that's on me as a leader of this company, like, to make our group go to zero. Like that just absolutely wouldn't fly, right? And so the problems, and I think in that same context, the problems that your teams need you to solve are not the same as they were in 2015, right? Like the world of healthcare IT and the world of healthcare delivery at large is radically different in the last 10 years. And so that kind of that adage that, oh, healthcare is a slow moving beast, I think that really comes from people who don't really operate inside of healthcare, because healthcare, I can't imagine a system that has more high impact, where the decisions, as small as they might be, they may feel small, but they actually have like very amplified effects in the real world. And so I think that it's incumbent on all of us, as voices in healthcare and the delivery of healthcare through technology, to really be advocating for the evolution in meeting our customers, whether they're physicians and users, scheduling, reg, whatever it is, like meeting them where they are to solve the problems that they have today. So I think it's a point that's well made. I think the other kind of funny thing I joke about with fire, just since we happen to dip our toes in that boiling pot, is I look at fire as kind of like airplane food. It's good enough for everybody, but it's not great for anybody. So it gets the job done. You will get fed on that flight, but you would have wanted something else if you could have.
Sometimes.
But it's what we got. Yep. And I love it for it. And I think we need to lean into it, which is why organizations such as us, even at our, Epic's this big and we're this big, we're members of Sequoia Project, right? Like we want to help influence the future of how these things work, because otherwise, how can we solve and influence this future solutions in the market?
Adit, I want to ask you a follow-up question. There's some really fascinating things that are that Dick and Zafar have described, dynamics that are there living, that affect you and what you do. So there is a desire for application rationalization. There is a
Certainly.
desire to go, if we can, from 5 to 1, from 3 to 1, from 4 to 1 in terms of applications. You're coming in, you say, well, we have a pack, we provide all these things, it's all integrated. So there's an upside. There's still that element they talked about of it being difficult on their end. Even if they're on board, they love it, they've got users of those other 3, 4 applications. So they've got to have some work to do, some unpleasantness on their end. There's this concept of, if and when our our EMR provider has something good enough, we're going to look to go back to that, to go back in suite. That's a really interesting dynamic. You have to
Certainly.
stay ahead, right? You have to
Certainly.
stay ahead, so that never becomes a statement of truth, right? That statement can never be true. What we've got from our core EMR provider is good enough now. Have a good day. You have to innovate, as you mentioned, very quickly. I'd just like your thoughts on those dynamics.
Yeah, I mean, it's absolutely true. And I look at any one of the healthcare kind of EHR markets, if you will, whether it's Cerner, whether it's Epic, whether it's Meditech, or down in the ambulatory space like eClinicalWorks or whatever it might be. Everyone, they are not sitting still, nor should they. They have businesses to run at the end of the day, right? And as do I. And I think one of the things that becomes so important when you're looking at the future of healthcare is, if you're solving today's problems, that business will be fine. You'll run a 3 to 5 year business out of that. But if you're looking to solve tomorrow's problems, you'll build a lasting business, a consequence that has a positive impact on healthcare. And so when I, kind of honestly, Anthony, when I was talking a little bit about like, what do I view patient engagement as? Like, that's why I take such a broad view, because, there's things around like, how does the patient's beginning of their journey start, right? If you really start with the care journey map or like a discovery map, and you're thinking about it from a more lead perspective rather than just a patient perspective, it actually doesn't start with the health system. It starts actually at the need for care. And so how do we funnel that desire and that need for care to the appropriate place where, either BJC or Seattle Children's gets the opportunity to provide the care, right? And so, like, I think we need to be thinking as in our shoes, not only about, this very specific niche set of problems or platforms that we look to do, but how do we take those and expand those to all the different sets of problems that we have? That's just like on one end, right? Like that, patient journey map, and like where the journey starts ahead of the actual delivery and provision and scheduling of care, but also down like when it comes to the moment of care, how do we do things like modality switching to virtual when the provider is out? Here's a really great example. And so I live in Texas, and the pathototality for the eclipses in our region. And so I think maybe in St. Louis, you might have something similar to this in the BJC world, where it's like every health system is like freaking out in our southern region around patients who are going to arrive who are not necessarily registered, surge capacity in the ED, like all this sort of stuff. It's like, how can we provide systems that are nimble to things that are very topical, right? And the typical example I used to give for this 3 years ago was COVID, right? But I mean, that's kind of like now, but like the next generation of these sorts of things, there is always something which has a need for this innovative, thought forward, lean forward to not today's problem, but the next 3, 4, 5 years of problems. And I think that's where companies, in my shoe and kind of my peer group, for those who will have like lasting business as a consequence, that's where we'll really lean into is the innovation side of it, rather than just the solving today's problem side of it.
Very good. All right, Zafar, let me ask you, the patient engagement journey and it lining up with functionality you can provide in a digital sense. What are your thoughts there on anything that you're trying to provide to your patients right now about the journey you want them to engage on with you? Um, Maybe some of the trickier pieces that you're having a little bit of challenge with from one element, from one angle or another.
So the way we're approaching patient engagement in the digital space is purely centered around what do our customers actually want from us. So I don't profess to have a digital strategy that I came up with. I actually pulled together and have for many years a group of parents, caregivers, and patients, and we meet with them every month. And we sit down with them and we listen to what problems they have with our health system and what things they would like us to build to help them navigate said health system, right? Because some of the basics are still a challenge in healthcare, things like access, equity, technological access as well is a problem. 53% of our patients are currently on Medicaid, don't necessarily have the smartest phone at home or the best laptop at home, but still want to consume these services. So what we've found over the years is when we sit down with this group every month, certainly what I've learned is the average 12-year-old is way smarter than me in any shape or form when it comes to technology. I feel shamed most of the time when I'm listening to what they really want us to build and we haven't built it. But they'll tell you what they need. And so when we started this journey and got the request to build a digital front door to our organization, and yes, we centered it around putting in a new EMR, which was Epic and MyChart, but there were still other things that people needed that weren't necessarily available. So we decided, well, tell us what you need and why, and we'll listen, and then we will build around it. So I'll give you an example, for instance, something I never would have thought of, but when patients come to Children's and their parents are waiting for their child to go through the surgical suite, what was happening was the parents or caregivers would sit in the wait room and just wait for hours on end for news. They wouldn't move because they were worried major surgery was going on. And what the parents fed back to me was, well, sometimes I'm sitting there for 4 or 5 hours and I won't leave that room till I get word about my child, which means I don't even get water or sometimes food to eat because I'm afraid to go to the cafeteria because I don't know where my child is in that journey. Could you build something that would let me know where my child is in that journey so I could pop out for a sandwich? And we've like, that's pretty simple to build. We actually could build that. So we did. So now you can see through a code whether your child is in pre-op, post-op, recovery. So you can run out, grab a sandwich, come back, and not feel like you've missed something so critical that, would end your world. And so simple things like that would not have come from us. They would only have come from the people who live and breathe and do that on a daily basis. So that's how we sort of are architected how to build these tools. And if we had great partners, they would build those for us. Sometimes we have to build those ourselves.
It's an excellent point. And Dick, I'm going to get your reaction. I have heard this in other discussions I've had, and it makes me think that every CIO, Chief Digital Officer, has to appreciate the idea that there is no one size fits all solution for patient engagement. And everyone who I've heard speak thoughtfully about this says what Zafar said, which is you need to build what your community wants you to build. Now, a little bit more nuance on that. Dr. Chaudhry's universe is fairly specific. So he may need one advisory council. But if you're in a larger health system that's not pediatric focused, you may need multiple councils to address different patient populations to make sure that they are driving your strategy and you're not just getting some cookie cutter patient engagement playbook and rolling out things that perhaps your population doesn't value. Dick, your thoughts?
Yeah, I couldn't agree more. First of all, it does, as the environment becomes more complex, the necessity of digging deeper into the environment becomes greater. We're in greater metropolitan St. Louis. We deal with people from all ages. We deal with children's care. St. Louis Children's Hospital is a highly ranked children's hospital in the nation. Seattle Children's, by the way, I've lived up in Seattle for a long time. Seattle Children's is awesome, and I'm not trying to compete between the two, but I am saying that from that to the adult hospitals to the community needs, everybody I think knows Ferguson, Missouri, which is in North St. Louis, and North St. Louis in general is a very economically deprived area. We have a lot of issues where we need to reach out, and where we may not have the ability to reach out technologically because many of the people we're trying to reach have limited technical means. Interestingly, many of them are better with smartphones than they are with computers. Many of them have access to smartphones even if they don't have access to computers. So we really look from a digital front door perspective at a multimodal approach. Now, one of the advantages that I have is that I'm sitting here talking to you, but we have a digital front door team which really tries to think about all of this. They work with our marketing team. They work with the Epic team and with the clinical applications teams at BJC and at WashU. So it's a complex environment. Probably the biggest piece of this, though, is to understand it's not one digital front door. It's not one experience we want to funnel everybody through. It's really a collection of experiences based on your need, based on how you came to us, whether we expect to see you a great deal in the future. We want digital engagement with everybody. Everybody who comes through our doors, we would like to offer that and to make that a part of your journey. But it's very different if you came to us because from overseas, you recognized we have a specialist that does your particular thing, versus having a child born at Christian Hospital in North St. Louis, where we're dealing with social determinants of health as much as we're dealing with anything else, and we really want to be there for you in that digital way to the extent that you can appreciate it. So it's a complex strategy. It's something that we really do look for a lot of different avenues of approach, and one where this is I think the greatest success we've had is that we've had a lot of individual successes, and the greatest challenges are the overwhelming need. The fact that there's just never a time where we can say we've engaged enough. We do, by the way, and not surprisingly, have patient advisory councils at many of our facilities and in many of our specialties. And then we do a huge amount of market research and quite a bit of looking at analytics from the systems that we do run, understanding where people are accessing us, and trying to infer what they want. That's probably the least successful thing. I'm very much with Dr. Chaudry. Asking and listening is probably a much more effective approach than trying to guess.
Very good, Adita. Question to you. So we've talked about how our other panelists are working to make sure they're responding to the needs of their users. You, as a software technology provider, most providers have customer panel councils, that kind of thing, to get that feedback. You have to decide, you know, how broad versus how narrow do we want to be, right? Do we want to only serve pediatric institutions? Probably not. Maybe. I don't know. Do we want to serve everybody in healthcare? How do we define healthcare? How do we define a health system? What are the components it has to have? Question, long story short, how are you deciding on your roadmap, and how is that looking, and where do you want to be the best?
Yeah, I mean, I think much like, both Seattle Children's and BJC, have you guys have like evolved. It's a journey. Like you're not done when you say it's happened. And I was kind of thinking a little bit, Dr. Chaudry and Dr. Taylor, about kind of what you guys were saying, or a little bit around like, patient engagement isn't like they have a MyChart account, right? Like that's just not like the end of the story, right? Like, and for us, it's not like they have like a Luma account. Like that's not the end of the story. It's for us, a roadmap is really built around, we like to think about it, it's 60 to 70% of like what our customers are saying, the problems that they need to solve. And it's 30 to 40% of where we see the puck skating, right? And so there's a big part of it, which is active listening, understanding like I have a service line, Dr. Chaudry, the thing you're talking about, Zafar, about like specifically around the operative scenario in the surgical suite, getting those op time notifications around when, I can go get a sandwich. Like that's like active listening. Like how do we enable that? How do we like make that stuff work better for our customers? But there's a whole bunch of stuff, healthcare is one of those interesting dynamics where the regulatory framework telegraphs where the industry is going to go in 5 to 10 years. And so, I spent a fair bit of time thinking about some of that sort of stuff. So like HTI2 is going to like come around the bend in the next like 10 years. Like how should we influence that? What commentary process? What should our vendor like competitors? What should our customer partners like be like saying that they want the standards bodies to go and see where that goes? Also, I think everyone's talked about value-based care is coming, right? But for like for a lot of different systems, value-based care is becoming a larger part of their payment in their revenue stream. And so as that continues to evolve, like what are the solutions we want to put into place? That's another 30 to 40%, Anthony, of the roadmap development, which is like looking to see what is happening in the ecosystem and making educated guesses around building products. Because, if we only built to what our customers are saying, to quote, to bastardize Henry Ford, we'd build a faster horse, right?
That's a good one.
So, but we do need to make great stuff to make sure the horse continues to function. And that's like, we have to understand that we have to like feed and nurture kind of with active listening what our customers need today. Because for me, a lot of either it's that 60% or the 40%, it's not about solving a problem. It's about building workflows that can help solve sets of problems. And so if we can kind of continue to evolve our product, evolve our roadmap to really with that active listening and kind of going with the puck of skating, I think it'd be really, we'd be very blind to say like, okay, we're going to build a faster text message. We're going to build a clearer phone call. Sure, those things have to happen, but like, are we thinking about like next generation things like, and I'll make this, I'm completely not saying we're going to go do this, but what should Luma be doing with augmented reality and like the Vision Pro? The answer is probably nothing. But like there are these bigger like things to think about, and that's where that other 30 to 40% comes, Anthony.
Yeah, and I think that makes a lot of sense. We also probably wouldn't have the iPhone if Steve Jobs didn't envision. No one was asking for it, right? So there is that concept of responding to what your customers are requesting, and also thinking about what they may not even realize they could benefit from. So that makes perfect sense.
Absolutely.
I was just gonna read. We're not gonna get into this, but industry legend and good friend Bill Spooner says, "Hello, Dr. Taylor." Right? Industry legend. We know that. Real quick on an answer for this. So I'll put this in front of you guys real quick. Are you winning or losing the application rationalization war? Um, so it's kind of a fun question, but let's make that a quick answer. Zafar, winning or losing?
I think I'm losing.
That's honest. That's
I have to say.
I love it. Dick, winning or
Today
losing?
I'm winning.
You're winning
Today I'm
today.
winning.
Today you're winning. All right. Awesome.
And I'll throw one in. I'm causing confusion.
Yeah, please
so.
go ahead. Go ahead.
No,
Are you causing
I said I'm just
confusion?
making the war go on longer.
Yes,
Yeah,
yes.
yeah,
You
that's
have
right.
you have a certain vested interest in,
Yeah, exactly. And I'll be the first to say it.
in adding applications. Um, David Muntz, also another industry legend and our good friend. Um, he makes the point, and Zafar, you touched on this, ethical implications of waiting for an incumbent vendor to develop something that the users are saying they need. You're both physicians, Zafar and Dick. You're both physicians, so that is interesting when clinicians are making a case for an incumbent product not being good enough, right? You have a bit more of a sense to understand whether or not what they're saying is accurate. Especially when it comes to clinical things, at least you have a better ear to hear if that's making sense. I've heard the 80-20 rule, meaning if what we have can do 80%, it should be good enough. But it is a great point. I've also heard this come from both different sides. I've heard really smart CIOs say, we will always opt for the incumbent product or the in-suite product, which is very extreme. And I've heard CIOs say we will always get what our users want and integrate, which is also pretty extreme. I'm guessing most people wind up somewhere in the middle. But any more real quick comments on the ethics? You have to, if you say we're sticking with what we have, you must really believe there's going to be a serious lack of integration on bringing in that outside product, and that is going to cause harm. So you have to believe that in order for you to have an ethical framework to say, we're not going to go with what you say you need. Anyway, real quick on the ethics of making these decisions. Dick, let's start with you.
Sure. So from an ethical perspective, the patient comes first. The first issue is always patient care. But within that, you also have to consider other ethical issues like stewardship and like the ability to provide other services and other care. It's never just one decision. It's always intertwined. Couple of things, as you said. First of all, if someone comes in and says it's patient safety, that's nice, and that button works. The patient safety, it's like the code button; it always works. But I also ask how. What are the implications? What happens if we don't do this? Because not doing it is always an option.
Yeah.
I would also say that ethically, one of the things we have with our primary vendor is trust but verify, which is to say we will spend a little extra time and a little extra money making sure that this vendor can't deliver it, and then going to the outside vendor. And we've done that many times. We resist proliferation in part by considering it a bunch. And then the other thing, as I said, from a life cycle perspective, if not now, when, and what's the criterion, and get that up front so that you can say at an appropriate time, yes, this particular piece of it has moved into something that our vendor can do. And so, and that's, but always with always with the eye that if it compromises patient safety, we're not going to stay with the current vendor. And we're pretty hard-edged about that.
Very good, Zafar. It can't be an automatic out, right? Hey, patient safety, I need this. Okay, you have
No, I
it.
think,
Not good enough.
well, aren't most things a patient safety issue in the
Right.
hospital environment, right?
Yep.
So I think it requires more stakeholder engagement and collaboration. I think a lot of times, yes, I've seen the scenario where the CIO will hold the line about it needs to be a single application, but I think it's probably better to get 5 smart people in a room to discuss the problem you're trying to solve and how you're actually going to solve it and why there's a need versus what is the risk profile around it. And I think sometimes we don't always necessarily do that. So you've got to be willing to listen and open-minded, but at the same time, I always say to my clinical staff that I'm always happy to be proven wrong, right? Because fundamentally, we're all going to learn from things and decisions that we make. But no, I think having a hard line is a difficult thing when you're dealing with patients' lives. You have to be open to listen, have a cross-section of views. Also, look at the finances of it, because I'm going to have to throw that out in today's world of low margins. You can't just go down the path of buying millions of dollars worth of new software if you don't have the funds to sustain it as well. So, you need multiple people to make that informed decision. So, similar to we try to give the patient informed consent. Well, I think in the world of software, you need that informed consent as well before you make that decision. And at the same time, take the opportunity to gain from a changing market. So you do have visionaries in the vendor space bringing new tools and technologies. Sometimes you can capitalize on that. to help your patients.
Excellent. For time purposes, Adita, I'm going to throw it to you, and I'm going to get the last word from you, and I'll frame it up this way. In this discussion is going to inform a lot of the evaluations of your software, right? Because when you go in and you're speaking to health systems about what you offer, you know from, and you probably knew before from this discussion today, the things they have to think about, the things they have to work through. And again, the benefits of the product have to surmount any of the things that we've discussed. That's something that you obviously are being successful with because you're selling your product, you have customers. But what would your message be to CIOs about making this decision? And if they decide to go forward with a product like yours, any advice on how they're going to work through the sunsetting and some of those difficult political things that they're going to, if you're going 5-1, you've decided to go with me, you're going to go 5-1, you got some work to do on the inside, right? So any thoughts you have there as our
Yeah,
final
I
thought?
mean, probably two key thoughts as closing commentary from me. Like, it's been very clear in our conversation that, in both Dick and Zafar's like mindset, it's EMR first, but it's not EMR only, right? When there are needs in this bucket, like smart, thoughtful evaluation of what comes in this bucket, it can lead to really great outcomes that solve real problems and have real opportunities to make patients happier, staff, and users happier. And then the second part of your question, Anthony, when asking that question, I think, thinking through governance and then adoption are the key elements to kind of flip the script on how to make those difficult conversations. One of the things that we've done some of our partners, I should say, have done very well is using things like town halls to actually educate and inform before it's fait accompli, right? To bring people along as the decision has been made, but how the decision impacts their lives, giving people agency in that process. So I think it's like EMR first, but not EMR only. And when you decide to make an alternative choice or make a choice that sits with and well integrated in, bring the people who it'll impact along for the ride. That's worked very well in a lot of our customers' deployments.
Excellent, excellent. One of my takeaways on this conversation is the ever increasing appreciation for the healthcare IT executives and the art that goes into being successful at the job. I mean, very few hard and fast, absolutely yes or no, black and white decisions. It's a lot of art and a lot of working through conversations. And I love Zafar's comment that he's always happy to be proven wrong. No problem. Prove me wrong, right? We'll make a change. Okay, regarding continuing education, you could use the final slide in this deck. You'll get an email when the on-demand recording is ready for viewing. If you want to work with us, you can reach out to Nancy Wilcox from our team and you go to our website to register for upcoming panels. With that, I want to thank our tremendous panel, our good friends, Dr. Zafar Chaudry, Dr. Dick Taylor, and Adita Van Saad, and Luma Health for sponsoring and making this valuable conversation possible, and you for attending. And with that, everybody have a wonderful day. Thank you.
Cheers all.
Thank you.